Hello, ladies and gentlemen. Thank you for joining us for another session of the virtual operating room from the Neurosurgical Atlas. Today, our guest is Dr. Juan Carlos Fernandez-Miranda from Stanford University. Juan Carlos is an incredible surgeon. He is truly one of the most impressive rising stars in neurosurgery, and I'm absolutely positive we're going to hear a lot about his successful refinements of skull-base surgery in the next decade. Juan Carlos, I know you have been with us before. Truly, your contributions to skull-base surgery, endonasal surgery, technically, and also neuroanatomical research projects have been groundbreaking. So it's an honor for us to have you again for pituitary surgery innovations and challenges. And I know you have pushed the boundaries there, and we're all excited to learn from you. Please proceed.
Thank you, Aaron. It's again a pleasure and an honor to be with you again and continue our ongoing collaboration, hoping to influence the next generation of surgeons in the field of skull-base surgery, endoscopic endonasal, and today we're going to talk about pituitary surgery, in particular challenges and innovations in pituitary surgery. These are my disclosures, in particular may be relevant to this talk, the Keyless Martin endoscopic dissector setup design that you're going to be seeing the use in these videos. This is my team at Stanford. As I'll emphasize today, it's so important, especially for a pituitary successful practice, to have a good rhinology ENT team working with you, and to also have, very importantly, your neuroendocrinology team closely collaborating and working with you. These are beautiful hospital at Stanford, or new hospital. And I'm going to start by describing what I think are some basic principles of modern pituitary surgery that are relevant for me, important, very important for me. First of all, of course, is the importance of the use of a privileged visualization tool, which is the endoscope. And that makes a big difference, and that made a big difference about 2 decades ago, perhaps, where the endoscope was introduced and substitute the microscope for the most part, because the endoscope can provide this very wide angle view that the microscope cannot provide. Second very important principle, pituitary surgery is actually a skull-based surgery. And for a long time, pituitary surgery was like a reduced field and sometimes separate from skull-based surgery. And I think, in my opinion, as you will see today, that is not what modern pituitary surgery should be. It should be in the realm of a skull-based surgery. As our admired Professor Sekar say, there is no place for occasional skull-based surgery. Similarly, I believe there is no place for occasional pituitary surgery. I firmly believe in super specialization in this field, in pituitary and skull-based surgery. And I personally, as you will see, why I discourage community hospital pituitary surgery for the most part, and I encourage for centralization and referral centers for these complex operations, because the outcomes are dramatically different. Please run this video if you could. So a key principle of pituitary surgery nowadays is that this is endoscopic endonasal microsurgery for pituitary adenomas. We sometimes face very challenging tumors that in the past were inoperable through an endonasal approach, and we had to do combine or exclusively transcranial approaches. But nowadays we can do really amazing working endonasally using microsurgical-like techniques to remove these very complex tumors. There is this particular entity of subarachnoid invasion by pituitary adenomas that we always need to think about, because these tumors do not respect the arachnoid and they are very challenging. Some people call them aberrant adenomas because they are just not the usual good-looking behaving adenoma. They behave more like invasive tumors such as cranopharyngiomas, for example, or meningiomas, and as such, they should be treated. Let's go to next, please, Luke. Thank you. Along with that, it's important to use the proper instrumentation. So now for pituitary surgery, we use this type of micro scissors, or we use this type of dissectors, as I explained before. In my dissector set, there is only one ring curette, which is actually not used very often, but it has roton-like dissectors, it has angle knives. It's a different set than the traditional pituitary surgeon that has 20 different ring curettes. We only have one, and we have microdissectors and microscissors just like we do for microsurgery. Another very important principle is that we work with ENT, and working as a team makes a big difference. The whole is greater than the sum of its parts. And I firmly believe in the benefit of working as a team and collaborating. For example, in this case, this is, okay. Well, I'll show this case at the end, but this case illustrates, I want to illustrate that the collaboration with ENT is so important at multiple aspects, in particular for the approach and for the nasal care after the operation, but also because they provide superior operability because they drive the endoscope in a way that allows you to do a very efficient operation. And of course, their role in participating in multilayer vascularization, multilayer reconstruction with vascularized flaps is key. This is a case where there was no septal flap available, and we used an inferior or lateral nasal wall flap. And their participation for this part of the operation is really, really relevant. Let's go to the next, please, Luke. When we review our experience in Pittsburgh long ago, this is an old paper reviewing the experience in Pittsburgh for a decade, about 555 tumors. These were the outcomes we found. Vision becomes better in most patients and rarely worse. CSFT rates at the beginning were about 5%. Now we drop it to about 2%. And of course, there's always a risk of ICA injury. And there were 2 cases in that initial series with dramatically different outcomes. But we always worry about the ICA injury when we work in the pituitary region. My experience with this is being no injury to the ICA in the last 10 years and more than 1,000 in the nasal cases. I'm always extremely careful with the carotid, but at the same time, very aggressive to removing tumor around the carotid. With this, I want to send the message that we cannot take lightly working around the carotid very seriously, but at the same time, we can do very aggressive and effective work around it without injuries. And I'll illustrate that today. Also, we found that the resection rates were highly correlated with the degree of invasion, and this is very well known, of course. NOS grade correlates with the degree of invasion in the cavernous sinus and with the resection rates. But there are some things we can say and criticize about the NOS grade, and that's another point I'm going to make shortly. But because of this invasion to the cavernous sinus, pituitary adenomas become more difficult, more challenging. And that's why I had a long time interest on understanding the cavernous sinus anatomy and how to do an operation safely within the cavernous sinus. As you know, when we talked about the cavernous sinus from a transcranial perspective, we talk about the superior wall or roof of the cavernous sinus. And when we talk about also the lateral wall of the cavernous sinus can be accessed through a transcranial approach. Even the posterior wall can be accessed through a transcranial approach. Now, when we talk about endonasal approaches to the cavernous sinus, we talk about the anterior wall, which is this one right here, anterior wall. But we also talk about the medial wall of the cavernous sinus here. And we don't see it here, but the roof of the cavernous sinus will be there deeply. All those can be approached endonasally. We took a great interest in studying the dural layers of the cellar region. Everybody knows that we have 2 layers in the pituitary area, outer layer, periosteal layer, and inner layer, meningeal layer. This periosteal layer continues laterally here and forms the anterior wall of the cavernous sinus, one single layer right here. This medial layer of the cavernous sinus, this one right here in red now, goes around and forms the middle wall of the cavernous sinus. It completely surrounds the pituitary gland. That is the medial wall. While the anterior wall is this area right here. Now, there is a bifurcation of these 2 layers that happens right here at the floor. This bifurcation is what forms the cavity of the cavernous sinus, the envelope of the cavernous sinus that contains the venous blood, the carotid, and the cranial nerves. Now, based on this knowledge of the dural layers, we studied carefully the meningeal layer and what it forms the middle wall of the cavernous sinus, and we found all these ligaments. We call them the paracellular ligaments. And these ligaments go from the middle wall of the cavernous sinus to the other walls of the cavernous sinus and the carotid itself. They are not between the pituitary gland and the middle wall. They are between the middle wall and the other walls of the cavernous sinus. So they are inside the cavernous sinus. Okay, so there were other authors in the past that were pioneers on or understanding of the middle wall of the cavernous sinus and its relevance for pituitary surgery. In particular, Dr. Oldfield, with his unique and amazing experience with Cushing's disease, he described the occasional occurrence of tumors embedded in the middle wall of the cavernous sinus and actually nested within the middle wall of the cavernous sinus. And he described a technique to remove it, and showing phenomenal results. Similarly, this Japanese group of Dr. Yamada, they published this paper some years ago with extraordinary results in acromegaly, 85% revision rates, better than ever before reported. And they showed that there were 18 cases where they removed the middle wall of the cavernous sinus, 16 of them being positive histologically. And they don't really describe the anatomy or really the technique to remove the middle wall, but they saw these pictures and the middle wall is being removed here. So also their pioneer work needs to be acknowledged, because we stand on their shoulders and we continue understanding this better and develop this more accurate understanding of the anatomy. And when we looked at this, we found there is a very constant and a strong ligament, which is called the choroidoclinoidal ligament, CCL. CCL is a continuation of the middle wall of the cavernous sinus, of this meningeal layer. It goes like this, and then it goes in this direction. And this forms the superior anchor of the middle wall of the cavernous sinus. You can see it in this cartoon. This is the CCL. And the CCL is directed posteriorly to attach to the under surface of the anterior clinoid. But it also surrounds the carotid anteriorly, as you see right here. It goes in front with some attachment and goes around it. It forms like a collar around the carotid artery. This CCL is what we call the ventral aspect of the proximal dural ring, and is the superior attachment of the middle wall of the cavernous sinus. And it actually defines the clinoidal segment or the paraclinoidal space or clinoidal segment of the carotid artery. This is the clinoidal segment of the carotid artery right here. So when we look at the CCL from an axial perspective, you can see it has this trajectory, usually from the middle clinoid, goes a bit in front, but mostly behind the carotid to go to the anterior clinoid. And it can have multiple fibers. There are many variations here. Sometimes you only have these fibers. Sometimes you have all these other fibers here. And they can be all continuous, forming a firm roof, or discontinuous with holes that connect clinoidal space and cavernous sinus. Importantly, the fibers of the CCL then closely correlate with the interclinoidal ligament. The ICL goes from the anterior clinoid to the posterior clinoid. It's a well-known ligament because it forms part of the oculomotor triangle, but this CCL is located in front of it. So this is here CCL, and then all the way back, you're going to find the interclinoidal ligament, to the point that I know that all the choroidoclinoidal ligament has been removed or transected when I actually look and find the interclinoidal ligament. That is my key landmark. Different than the ICL, the choroidoclinoidal ligament is freestanding here. You can cut it. But the ICL is stuck to the dura. You can trim it, but it's stuck to the dura that forms the roof of cavernous sinus. Okay, so based on that knowledge, we are revisiting the anatomy of the clinoidal space from an endonasal perspective. And of course, we always need to correlate open and endonasal perspective. So endonasally here, we can see this is the CCL right here, thick ligament. And it goes underneath the carotid, a bit in front, but mostly underneath to go to the anteroclinoid process. The space that is leaving above this space here is the clinoidal space that contains the clinoidal segment of the carotid artery. Okay, the space below that contains the carotid here, that is the cavernous sinus segment of the carotid. Okay, as I will show you, tumors can selectively, more often, go into the cavernous sinus, but sometimes can actually invade the clinoidal space. And this is a very important consideration that I found in recent cases. So when we look at the anatomy from an open perspective, here we're lifting the roof of the cavernous sinus and we're finding the ICL, intercranial ligament, and there is a little fiber right there. We're starting to see fibers of the CCL. You remove all this dura, we can see CCL in this case. There is a big hole here, meaning this CCL is not very complete, but this is CCL, this is ICL. And this anatomy, again, defines the clinoidal space. And we can compare it again from above and from below. These are the fibers of the ICL going in this direction and attaching to the carotid in front and behind. And then this is the interclinoidal ligament here. Again, everything above this space is clinoidal, everything below is cavernous sinus. Okay, so with that in mind, I'm going to show you this first case, case example. Small tumor, patient, middle age, with prolactin levels elevated, present with sexual dysfunction, and he tries medication, but he's intolerant. And this is coming up more and more often in my practice and in the practice of others, where patients are not tolerating medication well. They have especially increased irritability, increased depression, and this cabergoline or bromocriptine medication really has some side effects in patients that appear to be subtle, but not so much. So we have a stronger consideration for surgery sometimes in these cases, especially as we become more confident with our surgical skills and outcome. So this is the tumor right here. And the location of this tumor, between the carotid here and the pituitary gland here, it is very suspicious for allocation into the clinoidal space. Look, can you play this video, please? This is the MRI. You see the tumor, how it's bracing the carotid. So this tumor, when I look at it, makes me think this tumor is invading into the clinoidal space. Okay, let's go to the next, please. Look. So this is the challenge of selecting curable prolactinomas. By this, what I mean is, let's play the video, please. Look, there are prolactinomas that are incurable with surgery because they are too invasive, but others we can actually cure and make a big difference in these patients. So we are doing a wide exposure. We are surrounding the tumor. You can see the tumor protruding through the dura and next to the clinoidal carotid segment of the carotid artery. So what we're doing is finding the pituitary gland, and then I'm going to find the clinoidal space. This is the dura that separates the suprasellar arachnoid. This is the carotid in the clinoidal space right there. So now I'm opening below into the cavernous sinus space. Now I'm going to enter into the tumor to the bulkhead some to make it easier, its removal. But just the bulking it is not enough because it has all these attachments where there is tumor. So I'm working in the clinoidal space, detaching, cutting those fibers of the carotidoclinoidal ligament. And that allows me to join the supraclinoidal, the paraclinoidal space from the cavernous sinus space. So I need to get a picture that is from this to this picture. Okay, again, I want to get from this. The tumor is invading this area right here. What we're doing now, cutting inferiorly here, the attachment at the posterior genu, so I can mobilize the carotid more. We're doing at this level is opening now below the CCL. We're opening right here. And now we are cutting through the CCL. Look at the beauty of those fibers. Those are fibers of the carotidoclinoidal ligament. The same fibers as this that you're seeing right here. And the tumor is growing along these fibers. This is something I'm finding more and more often, how tumors use the fibrous tissue to grow within, embedded in that tissue. So I have to go below, find the carotid in the cavernous sinus here. And then I found both sides of the carotidoclinoidal ligament, so I can transect it above and below. You can see the ligament right there. Now, we love to just get a clean cut on this ligament, but it's stuck to the carotid, so I'm going to coagulate it and then cut it, trim it progressively, and remove all the tumor, and whatever is left, I'm just gonna coagulate. So that's the residual attachment of the tumor, and all the way back, I'm seeing that interclinoidal ligament we were seeing right here, which we see right in there. Tip of the enteroclinoidal process, interclinoidal ligament. You see beautiful fibers of the interclinoidal ligament right there. That tells me I remove all the CCL. So that is an interesting resection involving clinoidal space and cavernous sinus. I'm not aware of any other publications reporting tumors invading the clinoidal space and surgery in this area. So we are preparing, our next paper on this topic. Let's go next, please, look. Now, when we go more inferior, within the cavernous sinus, along the middle wall, we find the inferior paracentral ligament right here. And this ligament has attachments to the carotid and to the anterior wall of the cavernous sinus commonly. You can see it right here in the cartoon. And it's a very relevant ligament because it is the first one we find when we open the cavernous sinus wall at this level. We're going to find this ligament. Now, this ligament is anchoring the carotid to the medial wall. So if I want to remove the medial wall, or if I want to get my way towards the posterior clinoidal process, I need to transect this ligament right here. So once you transect it, remember that behind you will find most often, the inferior hypophyseal artery. And that artery is at risk when you do these operations, as I will show you in some case examples here. So remember the IPL, inferior paracentral ligament, important reference for the inferior hypophyseal artery. There are other ligaments within the cavernous sinus with significant variability that we are trying to understand better, but this is what we found in our initial studies. These were published in this article, and then we had a second part. So with that anatomical knowledge, we designed this step-by-step anatomically based technique to remove the middle wall of the cavernous sinus entirely. And this is a technique that I've applied multiple times with excellent results, as I'll share with you. For example, here in this case, the tumor has been removed. And then our next step is to find the right opening point to separate the medial wall from the anterior wall. And then we can start mobilizing the middle wall of the cavernous sinus. The inferior paracentral ligament needs to be transected. Next, we need to transect the artery. We need to transect the CCL, coagulate the artery. And at the end, you get a picture where you see the posterior clinoid and the interclinoidal ligament. That tells you that you have removed the whole middle wall of the cavernous sinus. I always look for these two landmarks: posterior clinoid, interclinoidal ligament. Of course, inferior hypophyseal artery, posterior genu. There is so much important anatomy here to remember. The first 50 cases we did at the University of Pittsburgh. And our initial results were, excellent, with no ICA injuries. 4 patients, 8% developed a transient 6-nerve palsy, probably secondary from some of the packing material we used to control the bleeding. And histology confirmed invasion in 86% of the patients. So excellent results. Biochemical remission rates were super high, but this was very short follow-up. I'm sure there have been some recurrences since then. But now, when I joined Stanford, in the last 2 years, we've been religiously following and documenting our outcomes and registering our cases. Excuse me. We've done 120 pituitaries with in the last 2 years, and if you can look at the numbers, there are 105 primary tumors and 15 recurrent adenomas. Globally, we have removed the middle wall in more than half of these tumors. So imagine this, a routine pituitary practice. Mine is not routine, of course, there is a referral-based bias, but in my pituitary practice, more than half of the patients require middle wall resection, cavernous sinus surgery. That's why this is not just conventional pituitary surgery, this is skull-based surgery. I've done this, as you see, in all recurrent adenomas, 15 out of 15, all of them require this middle wall resection. which tells you why these tumors recur, because they are in the middle of the cavernous sinus or within the cavernous sinus. In spite of the complexity of these cases, we had, again, no ICA injury. Only 2 patients got transient diplopia. There were no permanent morbidity in this series. Very remarkable, we've been looking at the frequency and patterns of invasion based on cell lineage. And if you look at this data, we can see that somatotroph adenomas stand very much from the other cell types as the one that invade the most commonly, most frequently, the invaded wall of the cavernous sinus. In 87% of the cases, 21 out of 24, I removed the middle wall of the cavernous sinus in growth hormone adenomas. While this was done only in UC32, 38, 57% of the cases of other tumor types. And you can see the correlation with histology, how often the histology confirm positivity of the wall. Now, I know that I'm convinced there are false negatives here because, for example, some of these tumors are very difficult and there is a lot of coagulation artifact, and maybe you are losing the cells when you send them to the pathologist. So this is not 100% accurate, but many of them are being confirmed. And you can, for example, see strikingly how 10 out of 10 of the non-functioning gonadotroph adenomas had positive in the confirmed with histology. Now, if we focus on acromegaly patients, now we have 30 cases here because we have 24 plus plurihormonal adenomas plus a double adenoma that also cause acromegaly. That's why we have these mixed adenomas that produce acromegaly. If we put all the acromegaly cases together, 30 cases that I've done in the last 2 years, and we look at the correlation between medial wall invasion, histologically confirmed, and NOS grade, we are finding something that is striking, which is that NOS grades is not useful to predict invasion of the middle wall of the cavernous sinus. It is not at all for growth hormone adenomas because we are finding in 29% of grade 0 and 57% of grade 1 that there is actually invasion of the middle wall of the cavernous sinus right here. And this is, again, quite remarkable and new knowledge we are providing. Grade 2s, 100% of them, all of them invade the middle wall of the cavernous sinus. If you compare these with non-functional adenomas right here, you can see that, for example, grade 2s on functional adenomas, all of them invade the middle wall. You look at the non-functional adenomas, just a few of them invade the medial wall. Grade 3, we know, not always non-functional tumors grade 3 invade the middle wall. Sometimes they are just compressing the middle wall. However, when you have a functional tumor, in our experience, they're always invading the medial wall. So there is something about the biology of these tumors that made them more invasive. And therefore, NOS classification cannot be applied similarly for non-functional and functional adenomas. In particular, I would say that it's not useful to predict cavernous sinus invasion in cavernous sinus in functional adenomas, or at least not as useful, not as reliable. Okay, so I'm going to show you a case that is, please look, go ahead. And this case, it was very interesting because, that's a grade 0 or a grade 1, if you will, NOS adenoma. I think it's a 0. But in this case, it is with acromegaly. You would not expect that it's invasion of the middle wall of the cavernous sinus. Not sure why the video quality doesn't look that good. Maybe it's the connection. But we do a wide exposure, and then we are going to focus on removing the tumor from the cella first. And this is the usual whitish, soft, growth hormone looking adenoma. But when we look at the middle wall of the cavernous sinus, we see these 2 implants right here. And this cannot be really taken with pituitary, with curette. They are stuck to the wall. So what I do then is I map with the Doppler the anterior wall. I find the spot to separate medial wall from anterior wall. I open it, pack it with flow seal, with hemostatic agents, and then I start peeling the middle wall off the anterior wall and the carotid. So what I need to think here now is inferior paracellular ligament, and behind I need to find the inferior hypophyseal artery. So I found those, coagulated the artery, cut it, and then once I do that, I start cutting the dura of the middle wall along the posterior climate process, as you see right here. The posterior climate process is the point where the medial wall becomes the posterior wall. So that's my landmark posteriorly. You can see the implant on the middle wall. Then my superior limit, as I do this resection, as I told you, is the carotidocranial ligament, which I need to cut. And I cut it all the way until I find the intercranial ligament. So as you see, this technique is totally anatomically based. Every step is based on the knowledge of the anatomy of the cavernous sinus to do this successfully and safely. Now, then we send this sample to the pathologist, and they will do H&E, and they will also do immunohistochemical studies to confirm the invasiveness of the tumor into the medial wall. And this is at the end of surgery. So there we go. So you saw that case that a grade 0 or 1 is embedded in the middle wall of the cavernous sinus, strikingly. Now, as the tumors grow and become a grade 2, a grade 3, more invasive, more extension into the cavernous sinus, we need to start understanding the concept of the compartments of the cavernous sinus. And something that I still am trying to understand is, there are tumors that grow within the structure of the middle wall of the cavernous sinus, and then they expand and extend into the cavernous sinus compartments, but they are still contained within medial wall and fibrous ligament structures. However, there are some other tumors that completely break through the wall, destroy the wall entirely, and they invade diffusely into the cavernous sinus. Why one thing happens or the other, we don't know yet. I don't know if it's the tumor characteristics. I don't know if it's the medial wall structure characteristics of the patient. Maybe both. But both are findings. But before, we had the knowledge that tumors just invade into the cavernous sinus, and you need to go there and just suck it out. But we find more and more often, very frequently, that tumors actually are contained in the wall, and that's fibrotic tissue. It makes it more difficult to be, entirely removed. So this classification of the compartments of the cavernous sinus is different than NOS classification, in the sense that NOS classification tries to predict the invasiveness into the cavernous sinus based on its grade and relation with the carotid lines. But our anatomical classification of the compartments is based on anatomy, of course, and it aims to help understanding the patterns of tumor extension into the cavernous sinus. We have a superior compartment above the carotid. We have an inferior compartment below the carotid. We have this compartment that is often forgotten, and it's so important because it's an area of residual tumor very often. It's the posterior compartment behind the gene of the carotid, just above the sixth nerve. Now, I'm going to show you an example of this, again, another prolactinoma, but in this case, this tumor was a resistant tumor with very high dose of cabergoline. The tumor continued growing. Yes, you can do radiation for this, but I think surgery is a more effective and, in experienced hands, a safer option with less side effects, at least in my experience, with no IC injury and no permanent injury to the cranial nerves. Radiosurgery has a risk, as you will see later, about 4% permanent injury to cranial nerves, and about 25% injury to the pituitary gland function. So that's the rationale behind being more aggressive with surgery. So in this case, we need to understand the superior compartment anatomy. And this anatomy of the superior compartment, there are three structures we need to remember. One, the intercranial ligament, as you see right here. And then that intercranial ligament defines a compartment above, or a triangle, the clinoidal triangle with the clinoidal ICA, clinoidal space. and the oculomotor triangle here with the oculomotor nerve. So clinoidal and oculomotor, and in between, the intercranial ligament. Key landmark and reference during surgery. So in this case, that's the prolactinoma. We're going to go, and what you're going to see is that this tumor that appeared to be completely made into the cavernous sinus, you think you can go there and just suck it out, you will see that's not the case. So you open the cavernous sinus, I can see the carotid very nicely, and then look at this. This is the middle wall of the cavernous sinus, right there, middle wall. So the tumor is displacing the middle wall and embedding into it. So to remove this tumor, you not only have to remove the tumor soft part of it, but you need to remove the attachments because the tumor is growing into them. And that makes the operation significantly more challenging. Again, you can see the CCL, that is the carotidocranial ligament, where the tumor is extending. We are cutting the attachment of the posterior genu, where the inferior hypophyseal artery is, and then we're cutting the dura of the oculomotor triangle, because the tumor is embedding that dura. And as we cut the dura, we find the the intradural space. But remember, this is our intercranial ligament right here. And if we know that's the ligament right here, the third nerve is going to be here. This is clinoidal triangle. Okay. So supracranial carotid right here. This is PCOM. And then the whole superior compartment has been accessed and the tumor removed from there with identification of the third nerve, clinoidal segment, oculomotor segment. And this is the post-operative video where we can see the post-op MRI here and the post-op MRI with a complete tumor resection. And normalized prolactin, this patient is 6 months out of surgery with still normalized prolactin without any medication. Okay, so that's an example of going into the cavernous sinus superior compartment. Now, we also need to understand, of course, very importantly, the inferior compartment of the cavernous sinus. The has the sixth nerve running just below and lateral to the carotid. We sometimes find the sympathetic nerve, and it's important to understand the short vertical segment of the carotid artery. And I'm going to illustrate this with a few cases. So when I look at MRIs, I look at the inferior compartment right here, below the carotid, and that tells me that I need to work in that compartment. The posterior compartment is behind the carotid. It's just here. So it's this area right here. And I know that at the floor of this compartment, I have the sixth nerve. And I'm going to talk to you later about how to find the sixth nerve effectively. But the key is this one right here. Finding what we call here the petrous apex. That is often the petrosal process of the sphenic bone. And this shape is where the sixth nerve turns and goes into the Dorellos canal. I found that dura that is curving as my landmark to find the sixth nerve behind the carotid artery. And that is an extremely effective way of finding it. So posterior compartment, where tumors like this, for example, are invading. Posterior, inferior, superior. So let's see this case. This is a young female patient, non-functioning adenoma, invading the cavernous sinus, likely based on imaging. You see there is tumor here. That tells me superior compartment. Right here, superior compartment, but also posterior and also inferior. So let's do this operation. Now, young patient, should we just be conservative, leave tumor, and then do radiation? I know many surgeons advocate for that. I believe that if you have the chance of curing this tumor, you should try if you have the ability to do it safely. It's always be better than adding radiosurgery to the mix if you can remove it all completely. So we are opening the dura of the cavernous sinus of the sella. We are removing the tumor in the sella. You see a nice clean pituitary gland here, and now we start seeing the tumor that is going to invade into the cavernous sinus. So I open the anterior wall of the cavernous sinus widely because I need to see the tumor inside and I need to see the carotid artery. So this is a soft tumor. That makes it easy. We see an inferior hypophyseal artery branch. We're coagulating. We see another one. Sometimes there are two, or branches perhaps. So we need to coagulate that one too. And then I'm always thinking about landmarks. So I'm thinking about, I need to find the intercranial ligament. And here it is, intercranial ligament right there. You see it very nicely. And whatever is above is clinodal space. That is clinodal space right there. Whatever is below is oculomotor triangle. That's what my third nerve is going to be located. So now I'm working in the inferior compartment. And this is medial wall, what is left of it. In this case, it was not all destroyed. This is medial wall, still here, with tumor on it. But it destroyed other parts and it spread through the cavern of sinus. So we are cutting this middle wall, and then we're slowly going to get access to the carotid right here. So I keep opening the anterior wall of the cavern of sinus. This is a cartouche stimulator that helps me to confirm the location of the sixth nerve. It really doesn't find the sixth nerve for you. It confirms the location. So as I see the carotid, I go slowly. Now the sixth nerve is going to be right here. And that is my sixth nerve right in this area. And now I can stimulate it. And that is useful to predict whether the sixth nerve is going to be functional right after the operation or not. And in this case, the patient had an excellent outcome with no sixth nerve palsy after the operation whatsoever. Working in front of the carotid, working behind the carotid on the inferior and posterior compartments, and finding the sixth nerve on both areas. And now working again into the superior compartment, working around the intercranial ligament towards the oculomotor triangle. And you see the carotid has been fully skeletonized. The middle wall has been completely removed, what was invaded. Compartments have been explored. That's proving that the third nerve is intact also. There is still a bit more of middle wall that is invaded, so I'm removing it. And this is at the end of surgery. Whatever remains, I can coagulate to assure that the tumor will not grow, and I'm just checking for any residual on the suprasellar space, arachnoid, and a nice clean resection. And this young patient has the better chance of not having a recurrence ever with this more aggressive type of operation. Again, no complications, intact pituitary function, and an excellent outcome. So, and this is the post-op, as you can see, and she's probably 2 years post-op at this point. Let me go next. So this is the post-op. So another case, this is also a non-functional adenoma. And this looks more complex, superior, inferior, posterior, maybe a bit of lateral compartment, but also look at the carotid, it's very loopy. So this is a more ugly tumor. Okay, and this one, I'm just gonna jump to a later area here. So that's a beautiful view of, let me ask you to just go back a little bit because I wanna show you a couple of concepts here. First is the carotid, extending into the inferior compartment, taking tumor from there. We're going to find the sympathetic nerve right there. That is sympathetic nerve that joins the sixth nerve. If you stimulate, it will stimulate the sixth nerve right there. So sympathetic nerve. Now I keep taking tumor and I'm going to move towards the posterior compartment. But as I take tumor and I go to the posterior compartment, I coagulate and I'm going to find Dorello's canal. And you're going to see this is Gruber's ligament. Pituitary ligament that covers the sixth nerve posteriorly. So the sixth nerve is just in front of it. And then I find arterial bleeding. And that arterial bleeding is a bit scary because it's right on the wall of the carotid artery. And that's the area we need to be extremely cautious always. That's why I like to identify the inferior hypophyseal artery and coagulate it early on. But with good bipolarness, you can coagulate the injury right at the exit and be done with it. So you need to be very comfortable managing arterial bleeding from branches of the carotid artery. And ideally, make sure you don't avulse them from the wall of the carotid. But look at how loopy is this carotid. So you need to have always a three-dimensional configuration of the carotid artery within the cavern of sinus when you are working in this area. Okay, so maybe there is a post-op for this patient. Let's say this is the post-op, and again, this patient has a complete tumor resection, no residual, no recurrence. Now, another challenge, this is a functional tumor, patient with severe acromegaly. Look at the extent of extension. Uses a NOS3, NOS3B, it will be called. Superior compartment, inferior compartment. Inferior compartment here is clearly invaded. Now, what I want to illustrate with this case is two things. One, how this tumor, I'm going to show you that is not like the others that are fully embedded into the cavernous sinus. This tumor is completely contained within the wall of the cavernous sinus. You have to find the ligaments, cut the attachments, peel it off directly from the carotid artery, which is an increased level of complexity. Second, you see how low this tumor goes right here. This is the level of the foramen lacerum right here. If I really want to get a clean margin of tumor resection here, I need to expose the foramen lacerum. And that's what I'm going to do in this case. So we talked about the foramen lacerum anatomy. This is the paper we published. I think this is very important anatomy, complex to understand, to me, long time to understand this well. But the most important concept I want you to take with you is the anatomy of the pterygosphenoidal fissure. Okay, the pterygosphenoidal fissure is this fissure right here. And it's a fissure that goes between the floor of the sphenoid right here and the pterygoid bone right here. Okay, between pterygoid and floor of the sphenoid, there is a fissure right here. Pterygosphenoidal fissure is formed of fibrous tissue, of course. You can see this in the CT scan. You see this right here. There is that line. This is the line. And this line forms a confluence with this other line, which is the Vidian canal, which is right here. So this Vidian canal comes like this. This fissure comes like this. They join at this level here, which is called the pterygoid tubercle. This is the name of this area right here. Pterygoid tubercle. They both confluence. This is a triangle. This triangle takes you directly to the foramen lacerum. You follow Vidian nerve, which is the classic that Professor Kazan described many years ago. But I found that if you also take this key landmark in consideration, the pterygosphenoidal fissure, this takes you directly to the inferior aspect of the foramen lacerum, right on the carotid. And the way to expose this is by drilling the floor of the sphenoid here, the pterygoid here, and you keep following. This drilling takes you directly following the fibrous tissue, as you see right here, takes you directly into the foramen lacerum. To me, this is the most difficult part to expose the carotid. But using this technique, this has become much more simple. And as you see, confluence of the fissure, Vidian nerve, and here is where the pterygoid tubercle was located. When you remove it, you are directly on the carotid artery at the foramen lacerum. Very important technique. To some extent that some of my fellows started calling this the Miranda Triangle. And last time we talked, Aaron, we talked about naming some triangles, but I don't mind as long as this helps people remembering this triangle, because I think it's very important triangle for me in doing these operations. Vidian nerve, pterygosphenoidal fissure, they form this triangle, and it's a true triangle as you see right here. And the apex of this triangle takes you directly to the foramen lacerum. Now remember that this triangle is not a perfect symmetrical triangle because the Vidian nerve is above, the pterygosphenoidal fissure comes like this from inferior to superior, and you need to find it deeper. So it's more like a pyramid in a three-dimensional perspective. But again, key landmark and technique to find the foramen lacerum. Because if you find the foramen lacerum right here, you see this is the lateral and inferior compartment, and it can be expanded all the way down here. And this is the posterior compartment right here. And often this posterior compartment is extended and eroding the bone all the way down here. So you need to have control of the carotid. If you're going to do an aggressive resection, you need to have the control of the carotid right here. So from here, you can start exposing it all the way and working behind, in front, etc. That I found to be very safe and very effective. And in fact, this foramen lacerum exposure is key for many operations, not just for pituitaries, but for many skull-based tumors, because this ventral foramen lacerum is a crossroad. From the foramen lacerum, you can extend, towards the petrous apex, along the carotid canal, towards the middle fossa Meckel's cave, towards the jugular tubercle and hypoglossal canal, and inferiorly laterally towards the jugular foramen and infrapitulus region. So it takes you to so many areas. And that's why it's so important to understand how to expose this area safely and how to work around it. Okay, so we go back to our case, this complex acromegaly. This exemplifies very well why these cases are true skull-based operations. So in this case, this patient again had severe acromegaly, and the first part of one of my first moves is to find the foramen lacerum before I, take any tumor out. And I'm drilling the floor of the sphenoid and the pterygoid. This is the stump of the Vivian nerve. I look at the fibrous tissue, I found it. And once I found the fibrous tissue, I follow it and remove the bone, pterygoid tubercle, and I find the carotid right on. This is the Doppler to check it, and this is my carotid artery. So at the beginning of the operation, I have the carotid control at the most difficult part, which is the foramen lacerum. Then after this, I just need to have my inferior limit. I just need to start opening the cavernous sinus. And you will see this is all so fibrous and it's completely stuck to the carotid. And it's stuck to the carotid because of these ligaments, these ligamentous attachments. So I have to sharply dissect and transect those. And you see, as I pull a little bit on this tissue, you can see that the tumor is growing through that wall, but it's still embedded in that fibrous tissue. So I detach it superiorly from the cranioidal space and superior compartment. This is inferior ligament, which I'm transecting. That's inferior hypophyseal artery, which I'm coagulating. There are several attachments along the horizontal segment of the cavernous carotid. I need to coagulate, cut, until I get all the way back to the posterior climate. This is much posterior climate, which forms my key landmark, as I said before. And now we are in the inferior compartment, taking these attachments, separating from the carotid artery, finding the sixth nerve, and then again detaching the last bits of tumor from the carotid artery, opening the inferior compartment, and finally detaching this from the foramen lacerum carotid almost. And that's where I cut it. Coagulate and cut. And then this tumor has been, now look at the ligaments of the fibrous tissue that embeds the tumor. And now we have removed the tumor. Look at this fibrous piece of tumor. This would never come with bipolar, with suction. And now we're looking at any residual, we're exploring again the clinodal space, superior compartment, clinodal space here. The whole carotid has been skeletonized completely. And this is an aggressive resection for an aggressive disease. And his IGF-1 at 2 months post-op is already normalized with a post-op day 1 with almost 0.1, which is equivalent to an excellent prognosis in the long term. Let's go to the next, please look. And finally, we have also lateral compartment. Lateral compartment, key parts of the lateral compartment are the infralateral trunk. It's not about the inferior hypophyseal anymore. It's about the infralateral trunk here. It's also about the proximal dural ring, but now on the other side, the carotid oculomotor membrane, which you see right here. So artery here, carotid oculomotor membrane here, which you can cut to mobilize the carotid more, and then all the nerves along the lateral compartment. And we do this in this operation in this compartment more selectively because the risk of injury to the nerve is higher. And unfortunately, at least in my series, I don't have that many of these very high-grade NOS4 going lateral to the carotid. But when I do, if the tumor is amenable, I can do some aggressive dissection, as you see in this pre and post-op. Now, to summarize all this anatomy and technique I've shown you, endoscopic in the nasal cavernous surgery is all about dissecting the cavernous carotid artery, understanding very well it, segment by segment, ligament by ligament, compartment by compartment, so you can do an effective operation here. And things I've learned along the way is that key landmarks on each compartment, which actually did not describe this in the original paper on the compartments, and this is something that has come more recently as I get more and more experienced, is that for the superior compartment, my key aspect is the key landmark is the clinodal space and CCL. Inferior compartment, to access it, the foramen lacerum is key. Posterior compartment, I need to remember the petrosal process, which I'm going to explain to you in a minute, is right here. And the lateral compartment is about maxillary strat, which is right here, and mandibular strat and optic strat right here. We need to expose from here to here to have good exposure to all the lateral compartment here. Okay, so we look at the significance of our results by analyzing our 30 patients with acromegaly. Does this technique and anatomy make any difference? So we look at the post-op growth hormone levels in our series. The mean on 30 patients is 0.9. And this is better than reported by excellent pituitary surgeons with great experience. And it's better because our techniques are more aggressive and more evolved. And I believe we can get better results, not only in the early growth hormone levels, but also in the remission rates for acromegaly. These are based on meta-analysis between 50 and 60%. And in our series, we have a remission rate at this point of 93%. All 30 patients except 2 were in remission. The 2 patients that are not in remission are now in remission with adjuvant treatment, one radiosurgery and the other one with just medication. And we have 3 of these patients that needed 6 months to normalize their IGF-1. So I advise being sometimes patient. If the patient have no symptoms or no significant symptoms of acromegaly, wait, because maybe it takes a bit longer for the IGF-1 to normalize. This is also being described and known before. But these results are, at this point, the best ever reported for remission, surgical remission in acromegaly patients. And just to remember, as we said, radiosurgery is of course an option. One of my patients got radiosurgery, but just one, because radiosurgery has a new risk of endocrinopathy of about 26%, and new cranial neuropathy that is a permanent one, not the transient we get with surgery. Sometimes the patients get better in weeks to months. This is a 4% of complete palsy and permanent. So radiosurgery is not safe of complications. Now, to finish, I'll show this last case. This is a patient with Cushing's disease. And this tumor illustrates so many different things. So let me stop the video here because I want to show you some anatomy about this case before. So there you go. So this case has invasion around the foramen lacerum and both petrous apices, as you see there. You can see carotid to some extent. Anatomy that is key that we need to understand here is the petrosal process of the sphenic bone right here. Why is this important? Because the sixth nerve is going to run like this, just above it. So you can find you expose the carotid, so the carotid runs in the bone right here. This is the carotid runs. If you find the carotid, you sneak behind it, you can find this bony slope, and you can tell that that's where the sixth nerve is located. Again, the technique, the carotid is being mobilized. I can find this bony slope, and that's where the sixth nerve is located. And even more, if you have tumor around the sixth nerve and you have to manipulate the sixth nerve, it's always best to drill this bone. It's difficult. Sometimes you have to use this ultrasonic bone curette because it's very narrow space. But if you remove part of this bone, the sixth nerve is more free and you can work around it with less risk of injuring the sixth nerve. So another key detail on this case has so many complexities. You see that the tumor has a bubble here. And we describe this. You look at this carefully. There is a line right here. This line goes from the clinoid, anterior clinoid, to the posterior clinoid. It's the interclinoidal ligament. What is happening is this tumor is breaking through the oculomotor triangle. We described this some time ago, how to go through the oculomotor triangle to follow tumors. You see the intercranial ligament here, the tumor growing through it, third nerve here. In the past, we had to use transcranial approaches to get to these tumors. But nowadays, we've learned to just go endonasal this way, and we just follow the tumor, and we can remove it completely. All in this one single approach. The anatomy again. Remember the intercranial ligament, the posterior pituitary ligament, anterior pituitary ligament. This is the oculomotor triangle. They break through this posterior part more often, and they displace the sixth nerve medial and superior, as you see right here. Okay, I think we are ready now to see this video. We have all the anatomy we need to understand this, and this video puts together all this anatomy. Previous operation 3 years ago somewhere else, never got in remission, severe Cushing's disease, young patient. As you know, this has extreme morbidity, this disease. So first, we go into the foramen lacerum, we follow the pterygospinal fissure, find the choroidal foramen lacerum and starting in the paraclavial segment. Again, you saw the fibrous tissue of the pterygospinal fissure, using the Doppler always, great adjunct for surgery. We can escalate the choroid from inferior to superior towards the cavernous sinus. Now, we are removing all the abnormal bone. Here we are transecting the pterygospinal fissure, and this is done to get access to the jugular tubercle behind. That is bleeding from the inferior petrosal sinus. We drill all abnormal bone, and I'm right now finding with my dissector the slope of the petrosal process. I'm cutting the dura, and now I'm working on the left cavernous sinus, opening the cavernous sinus wall, removing the middle wall, carotid all exposed, bleeding from the carotid directly from a branch, but I can coagulate it effectively, no problem, with good bipolar technique. You just saw the Dorello's canal. This is the sixth nerve. Again, petrosal process, and sixth nerve with tumor around it. And this becomes a challenge, so I remove part of the petrosal process so I can mobilize the sixth nerve and work around it more safely. But there's invasion in the Dorello's canal. So now I'm again back into the cavernous sinus. I'm working on each side of the CCL, joining the clinidal segment with the superior compartment of the cavernous sinus, transecting the CCL, accessing the superior compartment, identifying the interclinidal ligament right here, which I'm coagulating, transecting, and this gives me access to the oculomotor triangle, and I find the tumor that is getting into the oculomotor triangle, through the oculomotor triangle. We just saw the lateral wall of the cavernous sinus, all tumor is removed. Now we go suprasellar, and this tumor, as we started this talk, this tumor has subarachnoid invasion. This is a higher level of complexity. There is no respect for subarachnoid planes. You need to be extremely careful because the tumor is encased in microvessels. It's stuck to the nerves, stuck to the arteries. Difficult to remove. We can see the carotid bifurcation, the anterior circulation, the optic apparatus in the hemispheric fissure, the pituitary stalk right here. And you can see the third nerve. And the third nerve and the tumor right here. This is tumor that is going through the oculomotor triangle. Now, in this case, I'm now seeing the oculomotor triangle dura both from above and from below, which is a pretty unique perspective. So I'm removing this tumor that was extending through the roof of the cavernous sinus. I was at first trying to limit the dural opening because of the reconstruction challenges we have in this case, but the tumor was so invasive that I had to continue opening the dura to get better access to the entrance of the nerve into the oculomotor triangle. You see, there is still some more tumor around the oculomotor triangle dura. But after I cut this dura, I can mobilize the third nerve a little bit better, get better access to the dura, and clean it effectively. This third nerve, as you see it right here, was completely intact after the operation, not even ptosis. You can see the basilar bifurcation. Beautiful view of the third nerve all the way. And now we go back to the sixth nerve in Dorello's canal and removing tumor around Dorello's canal. And finally, the challenge with reconstruction. This is a lateral nasal wall flap, previous operation. Unfortunately, they destroyed the septal flap. That is very unfortunate because it increases the risk. In fact, this patient got a CSF leak and meningitis that we repaired with just a fat graft. But, remember, previous operation always carries significant risks. So that's why important, coming back to the first message, pituitary surgery has to be specialized because you can ruin, the future of a patient, and the next operations can be more challenging. So this patient, let's go to the next, please, Luke. I wasn't even expecting to be able to get a remission in this patient, but putting all this technique together and all this anatomy together, this patient crashed. Her cortisol levels were 2 at post day 1 and post day 2, and she was taken in replacement. as I said, intact third nerve palsy, not even a minimal ptosis, and left cranial nerve 6 palsy that actually has already 4 weeks out, or I don't know how much, but maybe 4 to 6 weeks out, has completely improved, and no 6 nerve palsy any longer. So in conclusion, I wanted to illustrate what I believe are some of the basic principles of modern pituitary surgery. The concept of supraarachnoid invasion makes these tumors very challenging sometimes, and it's key to do microsurgical-like dissection for these aberrant adenomas, where we can remove them all. Cleanup of the space, coronary ligament, superior compartment, middle wall resection, and the differential frequency on invasion based on cell lineage is new knowledge and concept we have been acquiring recently. The concept of cavernous compartments, anatomical classification versus radiological classification, and how NOS classification fails with functional adenomas. Also understanding key concepts, cavernous floor, foramen lacerum, access to inferior and posterior compartments, and finally, even access to the roof to get to the oculomotor triangle when the tumor extends to those areas. So as you see, from the lab to the OR, we can definitely improve remission rates and outcomes for pituitary patients. Thank you very much for your kind attention.
Impressive, really incredibly well done techniques. It's next level in pituitary surgery. There's just no question about that. This just shows really a true mastery of skull-based surgery through the endonasal approach. Juan Carlos, I really want to congratulate you because your work in this area has truly been pioneering. It's never been done before. It requires a certain courage, talent, and knowledge. I think all of those you have truly mastered. I just wanted to ask you a question which obviously comes to mind of anyone trying to do these operations, which obviously requires a complete level of technical talent, is if there is evidence of an injury to the carotid, it appears that using the bipolar first, if the injury is very small and potentially a perforator is evolved, you just go ahead and coagulate the wall gently. If that doesn't work, obviously then I use a thrombin-soaked piece of ENT cotton, shredded cotton, and I just cover the carotid. Obviously use the adenosine freely in that time because, as you know, the flow can be so extremely overwhelming. And using adenosine, even without a pacer, chest pacer or cardiac pacer, is very safe in patients who don't have a significant cardiac history and gives you just enough time to see what's going on. Can you give us other pearls in terms of managing carotid artery injury, Juan Carlos?
Sure. Thanks, Aaron. Thanks first for your comments and for having me again and for the opportunity. Yes, I think you mentioned very well. So if the injury is just a hole, as you saw, a small hole from the artery, biparody is extremely effective. But you need to have a little stump, I think, to be able to coagulate that. It's like side wall bleeding. Now, if you have a real injury, that's a different scenario. I always comes to mind, muscle patch, of course, crash muscle, a big chunk of muscle against the carotid, keep it pressure there with patties for a few minutes might make the trick if the injury is not too big. I also always have, as I said, I've been very lucky and very careful not to have major injuries to the carotid, but I've been involved in a good number of those. But I always have a tray in my cases that is not open, but it's immediately available with an aneurysm clip applier. It's a single shaft aneurysm clip applier. Because if you need to get proximal control or proximal and distal control, usually the carotid is all nicely exposed. You can try to get that too. And even you can try to do sidewall clipping of the carotid or put a little cotton and clip the cotton with the clip, as you know. So some sort of clip wrap reconstruction technique can also be used. I haven't done it, but I've seen that done and been successful with that technique too.
Yeah, I think one of the first things you want to do is just take a deep breath because, as you know, the flow is so extremely brisk, especially in the nose and the endoscope. It really overwhelms you. And I think that the best thing is just pack it with some cottonoid or patties and just take a deep breath because really gentle pressure controls that bleeding so effectively. So there's nothing to panic about. Panicking is the last thing you want to do, even though everybody panics. Believe me, even the ones who are calm, in fact, may be feeling differently underneath. But the first thing is just to pack well, take a deep breath, don't do the first knee-jerk response, and just after it's packed, find, use adenosine if you need to. It's very safe again. The dosing is relatively clearly known by anesthesiologists. And then as that's working for 30 seconds to a minute, you remove your patties, you inspect the area relatively well, and the shredded Teflon or shredded cotton with thrombin soaked with a gentle pressure can do incredibly amazing work. There's been times I've had carotid injury, I've put on there and continued resection. Obviously, we don't advise that. That may be a little bit too cowboyish, I would say, but I have done it in the past. And then obviously you have to do an angiogram afterwards. Rule out a pseudoaneurysm, do stenting if that's required, but you'll be absolutely amazed how many patients do well. So with that in mind, Juan Carlos, I want to again thank you for being such an incredible contributor to this series. Such an honor to work with you, and we're so impressed by your incredible contributions again. Have a good evening.
Thank you, Aaron. Thanks so much. Bye-bye.